Bonsoir, mesdames et messieurs, et
Good
bienvenue.
evening, everyone. Welcome to Procure en Parle. My name is Winston McQuaid. I'm a spokesperson for Procure and also your facilitator for our September edition of the Awareness Month for Prostate Cancer. Since information is our first line of defense, we're very glad to present the third of 4 weekly webinars this month. Today, we'll address urinary, sexual, and intestinal problems with Dr. Peter Vavassis, radio-oncologist at Maisonneuve-Rosemont Hospital. Please note that side effects of hormonal therapy will be addressed October 25th. So we'll have a presentation by our expert, followed by a Q&A period. I do want to thank those who sent their questions to info@procure.ca. If you want to submit questions live during the presentation, you may do that by using the Q&A feature at the bottom of the screen on Zoom. So right before we start, we'd like to thank our donors very sincerely, but also the official presenter of the webinar, Industrial Alliance, as well as our partners Estelas, Tolmar, and the Quebec and Canada Urologist Associations. Dr. Vavassis, thank you so much for accepting our invitation. The floor is yours.
Bonjour, bonjour tout le monde et merci beaucoup.
Good evening, everyone. Thank you. Let me go ahead and share my screen.
Ça devrait être à l'écran à l'instant. Donc, notre présentation ce soir.
So the presentation tonight will be about the side effects of the various treatment modalities relating to prostate cancer. It's interesting because we're going to start with a reminder how to pick a treatment. We can also look at what each treatment offers as well as what it costs. And in that case, we can compare treatments. It's a little bit different from just saying which ones have the best cure rates. Following that, we'll look at side effects, and each side effect has a treatment in and of itself. So we'll look at how we can manage side effects. And then, as we said, there will be a question period. We will look at different things that people will be interested in. And typically, if one person wonders about something, then many people do. I also want to remind you that hormonal therapy is of interest, but this will be addressed in another webinar in October. So first, how do we choose a treatment? If we look at that from the point of view of the treatment itself, what's important here is that there is no one-size-fits-all recipe. It would be easier, but unfortunately, it simply does not exist. So there are several elements that will contribute to a decision: age, health status, your general health condition, your life expectancy, the type of cancer itself, what stage also it is, we also need to look at values, what the patient prefers and wishes. And we also need to take the decision based on erectile function and urinary function. We'll look at the baseline, and then that will determine how we look at side effects later on. These are the types of treatments. So first of all, active monitoring. For some patient groups with cancers that are in early stages, one possibility is simply to have this period where we monitor the situation and make sure that the disease is under control. Of course, this helps to postpone any side effects since we're postponing treatments. This is definitely a benefit. So no urinary or sexual changes in this effect. However, there are disadvantages to this approach. We can be worried about the cancer being there and developing. We need to have a follow-up and potentially added biopsies, additional biopsies. And sometimes it's possible that between 2 appointments we see a change, and then at the next appointment we have bad news to give the patient. So for all these reasons, we need to be willing to undergo a certain stress with active monitoring. We could use surgery. If we do that, then we have tissues that we can send to the lab and that can be assessed. So we want to make sure that the diagnosis is right, that nothing was underestimated or missed. We also have an idea of whether the cancer was completely removed or not. And still, we have another option, radiotherapy. So the fact that we have other treatment options is reassuring in this case. There are disadvantages, however. It's more invasive. What we mean by that is something, let's see, it's a modification of the body. It's a permanent change in this case, a permanent modification. And there can be outcomes related to that. You do have to have a catheter for a certain period of time, and with any surgery, there's a risk of complication, whether with anesthetics that are used or the surgery itself. So there are benefits, but it does require a certain investment from the patient. Now, radiation therapy. It is painless, or relatively so. It's certainly much less pain there versus surgery. It's not invasive. We're not cutting up any body part to do what we have to do. We can have 5 to 30 or maybe 40 sessions, depending on how long they are and depending on the stage of the disease. If there's a recurrence after radiation therapy, typically we do not move to surgery. However, nowadays, we have the opportunity to have other types of treatment. So it could be radio surgery, so a very precise type of surgery, or brachytherapy also. The main disadvantage here of radiation therapy is that we do not have the prostate in our hands. We don't hold it in our hands, so we can't examine it, and we can't validate what scans and MRIs indicated. We do need to understand that our capacity to diagnose cancer today is quite advanced. We have good imaging techniques, and typically we have a good idea of the stage of the disease. Still, the pathology lab is the number one criteria, the gold standard for diagnosing prostate cancer. Now, a special type of radiation therapy is called brachytherapy. The advantages here, we insert the treatment directly in the prostate or around it. We can also use some needles, regardless. The radiation is concentrated to the prostate, so no radiation throughout the body and no harm to neighboring tissues. We also are not harming erectile nerves, so recovery is fast. Again, the prostate stays in the body, so we don't have pathological assessment in this case. And for this technique to work, the prostate needs to be at a certain size and shape, so it's not an option for everyone. Now, if there is a recurrence, we could have remedial treatment, but it's not a standard approach necessarily. So each modality has benefits and disadvantages. Now, on to the side effects themselves. So surgery first. One of the questions that's frequent is, which technique is the best? Well, there isn't one single technique that's better than another. The first question is how experienced the surgeon is. If the surgeon has good experience, is comfortable with the technique, and has seen many patients, typically the success rate is quite high. So the success rates are actually pretty equivalent with all or amongst different techniques. We can use a robot or a laparoscopy. This means that the cut will be smaller, so less bleeding, but still the result, the outcome, is the same. I am not a surgeon, so we can just see here how this works. And what's interesting is not the surgeon here cutting this with without any tools, so we have more advanced tools here to do so. When we look at this globally speaking, because we're trying to reduce all patients to a single number, a single figure, and that's not possible. So globally, about half of patients post-surgery will have some level of erectile dysfunction. It takes 1 to 2 years to recover from the surgery, and many recover erectile function at least partly. About half of patients then have a degree of dysfunction remaining after 1 to 2 years. Erectile dysfunction now does not mean that libido and orgasms are affected. They're not. But we do have to know that there is no ejaculation, and without ejaculation, there is no fertility. So if we remove the prostate, then no ejaculation and no fertility. And what about the other 50% that do recover? Well, it really depends on the baseline erectile function, which obviously relates to age, and also the type of surgery, the preservation of nerves also plays a role. The extent of the cancer also plays a role, because the cancer could spread to surrounding nerves and harm them. Now, with regards to urinary incontinence, typically patients will recover in a few months. There could be some residual leaks, especially on exertion. So whether we're coughing or jumping, perhaps shoveling. So it's quite rare, though, that they will need protection because they're completely incontinent, but that does happen every now and then. These are numbers, again, that are quite generalized, of course. About 5 to 15% will experience incontinence 1 year post-surgery. Now, again, this very much depends on the baseline urinary function, age, and extent of cancer. The more, of course, we had to make incisions and remove tissues, the more normal bodily functions can be impeded. About 5% of patients will have bladder neck stenosis. This reduces urinary flow. It can cause a retention. And since this is a mechanical problem, the solution is mechanical as well. We need to dilate the bladder neck. But every time we do so, we can have scars. And so it's kind of a vicious cycle, unfortunately. Now, radiation therapy. During treatment, we do feel fatigue, but people can still do whatever they want and live their lives normally. There will just be some level of fatigue that's higher than normal. There can be effects with the rectum and urinary function. So the radiation focuses on the prostate, but can affect neighboring tissues. This can cause irritation. So it could affect the bladder and the rectum. When the tissues are irritated, it can cause pain. There could be blood. Again, typically, these are manageable. Now, with specifically brachytherapy, we have implants inserted in the prostate. The prostate will swell. This means that the urine does not flow as well. So there can be pain. They'll have a catheter for a few days or for some time. And there can be urge incontinence, but typically these will recede as the prostate swelling decreases. Again, with radiation therapy, if we look at the urinary function specifically, during treatment, there will be some disturbances. There are medication that can be prescribed for that. However, it's quite rare that there will be enough scarring to cause stenosis. There can be inflammation or irritation of the bladder. This is typically not a huge problem. If we examine patients, yes, there will be some level of irritation and swelling. Rarely, there can be incontinence. As part of my experience and according to the latest studies, this is, however, less than 1%. However, some patients will be more fragile with regards to the urinary function. They may get up during the night to urinate, for instance. And we see here 5 to 10% have long-term symptoms. This is all symptoms, any and all symptoms related to urinary function. So it could be leaks, etc. So quite rare. Now with erectile dysfunction, we need to nuance this a little bit. We don't compare populations that are equal, on equal footing. Typically, we have younger patients that use certain treatments. Typically, however, with radiation therapy, patients are older. So, typically, younger patients have a good baseline erectile function versus older patients have a different level at baseline before treatment. So typically, we see erectile dysfunction gradually unfolding with radiation therapy. The peak would be 5 years post-treatment. If we compare that to an older patient, we're in our upper 70s. Well, in this case, it's a natural process. So yes, part of it can be linked to radiation therapy, but part of it is simply aging. At 5 years, men have about the same rates of erectile dysfunction as those who opted for radical surgery. There's a little bit of a difference, but again, I attribute that mostly to the difference in age of patients for whom we use different types of therapies. Again, libido and orgasms are not affected. They're not part of erectile dysfunction. Some men can ejaculate after radiation therapy, and sometimes this is retrograde ejaculation, or actually if there is ejaculation, then it is retrograde ejaculation, which means the ejaculate goes through to the bladder. Of course, we have loss of fertility in this case, but for most patients, as they are older, this is not an issue. Now, gastrointestinal function. Well, intestines can be affected, but mostly the rectum is. So there can be tenesmus. It's a complicated word, just to say that the rectum will sometimes be tense without actually any reason to do so. It's unpleasant, but not dangerous. Now, inflammation for the rectum. Again, there is inflammation and swelling during treatment, since we have radiation going through. But inflammation is very clinical, quite limited, and it will remain pretty constant or it will not, rather, remain post-treatment, typically. There could be some bleeding, especially in the weeks following treatment. Then in subsequent years, especially if the patient is constipated, there could be a little bit of bleeding. So in this case, we may use colonoscopy or something else, but in most cases, things just resolve by themselves. About 5 to 10% of patients have long-term symptoms, but so the vast majority of them do recover fully. Okay, so again, monitoring. Again, one of the disadvantages is repeated biopsies and frequent monitoring activities for surgery now. we do have the prostate, and we can assess it at the path lab, but of course this is more invasive, and so there could be a little bit more complications there. We have radiation therapy. It's easier to go through than surgery. There will be no immediate incontinence or erectile dysfunction, but of course there will be irritation during the treatment. And in this case, we don't have what we'd like to have in order to see with the pathology lab what the cancer type is. And again, with brachytherapy, radiation is more targeted. However, not all patients do have that option. So now, how do we manage these symptoms? Let's start with erectile dysfunction. So if we do have erectile dysfunction, you know Viagra, Cialis, and such medication, so we can use that. We also have Muse. It's a suppository that we put in urethra. There can also be injections inside the penis. These are used, actually the patient injects themselves at the base of the penis. This will stimulate erection. We also have vacuum pumps. This is a mechanical way to stimulate the penile tissues. It helps to attract blood to draw blood into the penis. But if all of this does not work, we could have a prosthesis if the case is very serious. So this is an apparatus that allows you to have an erection. Some patients say it's not an actual erection because it's the apparatus doing the work, but still the outcome is the same. All of these are no substitute for the natural needs of the patient. So we do need stimulation in order to have sexual relations that are fulfilling. We also need resilience. We need to try different things in various conditions. And I would add also, communicating with your partner is extremely important. This very much goes along with the mindset of the patient. If you're anxious, if you're trying different things and things are not working out, it can become more difficult. So communication is key with your partner. And mental resilience is as well. Just saying, okay, we'll just do what we can do here. This is essential in order to address the issue with a hopeful mindset. Post-surgery, we could have a penile rehabilitation. Globally, what this means, well, it's several interventions. It's not just a pill and that's it. It's rather finding strategies. They're both psychological, having the right mindset. And it's also supporting medication such as Viagra. And to that, we can add injections or a pump, depending on the need. And each patient can try and see what combination works best. Getting back to this idea of anxiety, we have to let go of this idea of performance. Erection is not the only way or the only parameter in satisfying our partner. But if we do believe that is the only thing, then it will foster anxiety. Ultimately, erection is very much related to the mind and the brain. So anxiety here will interfere. If you have to succeed with the erection, it's not at all the same as just having fun and being at peace and trying things out. So we have to be, yes, creative to a certain degree, and then erectile dysfunction improves along with your mindset. What about orgasm? Orgasm is not affected typically, so the feeling of it is unaffected with any and all methods that we can think of. Yes, touch and caresses play a role, and of course fantasies and imagination also do, and attraction of course plays a role as well. There can be a dry orgasm, so without an ejaculate. There could also be retrograde ejaculation, so the ejaculate goes to the bladder. So we shouldn't think that erectile dysfunction means no pleasure, no sensation. That is not the case. Now, with regards to urinary incontinence, what is this? Well, it's leaking urine. This can happen with exertion or without exertion. Sometimes patients say, I wasn't doing anything, I was just sitting, and there was some leakage without any trigger. This can happen perhaps while getting up or sometimes in the morning or evening. There are different causes and different solutions. Some patients have urgency incontinence, so you have very little time to find the bathroom. This means, or actually this often happens when people arrive home. There's a psychological effect, knowing that the restroom is nearby. So there is definitely a psychological trigger to this. Unfortunately, urgencies can be very sudden. The patient can just realize, oh, I need to urinate and don't have time to get to the restroom. And sometimes this feeling of urgency is false, because there is nothing to urinate actually when they do get to the restroom. We can also have difficulty urinating. There could be some pain, or the flow can be very weak. But all of this can be addressed. We can use physiotherapy to reinforce and strengthen the pelvic floor muscles. Very useful. The pelvic floor is really the region under, so supporting the bladder, close to the scrotum and the anus. So strengthening the pelvic floor will help with good control. We want to have the right contractions at the right time in order to control leakage. And the more control we have, the more confident we get. And this is a good cycle, a virtuous cycle. There are a few things also related to diet. I'm thinking specifically of coffee, and that can need an adjustment. If with your efforts still you have some occasional leakage, you can use appropriate briefs for that. We also recommend Kegel exercises, again, to strengthen the pelvic floor. More details about the diet. Avoiding coffee, tea, colas, anything containing caffeine, also spicy foods. In terms of protections, incontinence briefs, we should not wear them at night as much as possible if they're not needed. The idea is to have a little bit of pressure to not overuse them when we don't need to. I mentioned Kegel exercises that help also with these muscles and a better control. And I'm sure there will be questions about Kegel exercises, but the good news is you can do them anywhere, anytime. So very interesting. It's very, very helpful and easy to do. If we still have trouble, however, surgery can also be used. Now, with bowel problems, especially related to radiation therapy, there can be changes in stool consistency, or there can be emergencies to have bowel movement. There can be incontinence or pain and a little bleeding also. With most patients, what we do is tell them to adjust their diet. We can have intestinal rehabilitation. There can be some drugs that can be used in order to reduce spasms and pain. If bleeding persists, there are also laser treatments that can help to seal off the section that bleeds. And if the disorder is severe, we can also have surgery. So, key takeaways here. First, if you don't have treatment, there is no side effect. A cancer that's detected earlier is easier to treat, of course, and the treatment will come with less side effects. Treatments, regardless of which ones they are, can have consequences. With urinary, erectile, or intestinal functions, there are strategies to prevent these complications and manage them as well. If there are side effects to treatments, again, there are ways to manage them. There is no magical pill to cure anything. The patient does need to be mobilized and invested in their recovery. This is absolutely the determining factor for success. There we go. I think we can now move to questions. Fantastic. Winston McQuaid is back. Really, Peter, this was so helpful with the examples and a very solution-oriented talk. So I think this is very reassuring to people listening to us currently. So thank you so much. Let's move to the Q&A. So first, about erectile dysfunction. What about penile rehabilitation? What are the dosages and what's the frequency? And how long will rehabilitation take post-surgery before having a restored erectile function? Well, this is an excellent question. we broach the topic here. Penile rehab carries out several interventions. We can have drugs such as Viagra. We can have a mechanical intervention like using the pump. We can have injections as well. So all of these elements together will contribute. But of course, we need stimulation to be there. So a physical stimulation that's, of course, always required, but also psychological. Also, we need to manage expectation and anxiety and have the capacity to give it another try, move past any failures and try again. So this is a whole. This is all encompassed by penile rehab, what we mean by this. So of course, it will vary a lot. The more we practice, right, the higher the chances of doing it right. So this is as far as I can go with an answer. We can start relatively quickly, a few weeks, at least 4 weeks, and up to 8 weeks. We can start attempting to have intercourse. So starting 2 months is better than waiting for, say, 6 months post-surgery. There's an English idiom that says, if you don't use it, you lose it. I think everyone understands, right? Is this, how true actually is this? Oh, absolutely. It's like anything. Any bodily function. If we're not invested, then yeah, we might have a harder time. And I'm happy to talk about it. This could be a little bit taboo, but here I go. The significance here is we don't always need to have a partner. We could do masturbation, and this is still valuable, and I'd like to state that this is completely natural. And so we shouldn't forego this option as well. This is a question that I'm going to ask here. If we talk about masturbation, someone who doesn't have a partner, or someone living with a partner with a one-sided sexual activities, what would be the frequency then? Once a week, twice a week, as needed? What's your take on that? Well, as needed. This is actually a good point. If the patient is 75, most likely their spouse is also around 75, and perhaps the spouse isn't as invested in having intercourse, and that is okay. But it's also okay if the patient wants to have intercourse or to have sexual relations. So definitely simply as needed. If we decide that this is every 6 months, then you'll probably be disappointed if you only try every 6 months. Okay, another question. Is it possible to use a penile pump at the same time as an injection? And will injection work if we're under hormonal therapy treatment? Yes, great question. The injection here helps to draw blood into the penis. So if we're under hormonal therapy, and we said that we wouldn't address this today, but let me just quickly give it a go. So if we're undergoing hormonal therapy, there is a loss of testosterone. This will also contribute to erectile dysfunction. So the penis can work fine, but the chemical aspect of it is absent. Also, very practically, the pump is cheaper and it's very simple to use. So I always advise that first. I say, try this first, and if that doesn't work, then we'll try with injections. Typically, injections are pretty painless and effective. There is a subgroup of patients that can try both. That's fine. But typically, I do mention that this needs to be discussed with the physician, and we need to discuss the level of success of each strategy. Not just go home, be disappointed, not say anything, and then just trying different things haphazardly. Yes, again, communication is key, especially with your partner. This needs to be discussed. Some people are timid about it, unfortunately. It's still somewhat of a taboo. So this is very unfortunate. Not always easy. So I very much agree. We need to look at the relationship and communications aspect of this. Now, what's the recovery time for testosterone after hormonal therapy? Well, again, we said that we wouldn't address this topic, but no problem, I can answer the question. Oftentimes, here the key factor for recovery is the duration of treatment. It's easier to recover from a shorter hormonal therapy, so say over 6 months, versus hormonal therapy over 2 years. The baseline testosterone level also, of course, determines how much we can recover after treatment. Generally speaking, patients will recover about 3 months post-treatment. This is pretty quick, though. So typically a few months. But some patients required almost 2 years to fully recover post-hormonal therapy. So the longer the hormonal therapy treatment is, the longer the recovery time is as well. There can also be added testosterone. There can be testosterone that's prescribed as such. What do you think about that? No, not in the context of prostate cancer, no. And why? We don't want to stimulate the prostate. It's countering what we're trying to do. We're trying to stop testosterone in order to stop stimulating the prostate. So it would make no sense to then use testosterone. We should just skip treatment altogether if that's what we want to do. Okay. We have a patient treated 3 years ago with radiation therapy or brachytherapy. Sexuality is rare, low libido, inadequate erection, low ejaculation. I thought I would be better with radiation therapy versus surgery. Can we improve the situation? Yes. I have a lot of questions. So 3 years ago, okay, so how old was this patient when they started radiation therapy? So let's guesstimate. Let's say they were 72. Okay, so now they're 75. Second question, how was the patient's sex life before? Of course, that will determine the outcome post-treatment. Third, can we improve the situation? Yes. I don't know what this patient tried. Have they tried rehabilitation? Have they tried regular stimulation? Were any drugs offered? So yes, there are a lot of solutions, but the idea here is to look at what's realistic. If the patient is, 86, then there can be a good result, still a good outcome, but perhaps not what they'd like. So yes, we do need to be realistic. Now on to urinary dysfunction. How can we know the difference between incontinence on exertion and spasms? Okay, so the first question here is, actually the first answer is, we need to look at that with our physician. And I tell that to my patients. The patient's job is to describe the situation, then it is my work to have a diagnosis and suggest solutions. So that said, say we tried getting up, or we shoveled something, or we moved a piece of furniture. So there was exertion, and we felt some leakage. This is incontinence on exertion. This typically doesn't come with pain, but spasm is a cramp. We feel the bladder voiding. So there's a huge difference. And each case brings about different strategies. So try to know what is happening when there is leakage, to describe that to the physician. Recently, I have an inflamed bladder. My physician says that it's a side effect from the radiation therapy I had 5 years ago. Is this true? I would say, if I punch you in the face, it's not a year later that your face will swell. So no. However, if we have, say, a camera entering the penis to look at the bladder, and if there's chronic inflammation, yes, that could be related to radiation therapy. So the question is not, is there inflammation? Just like, as we age, we don't ask whether our hair is gray. The question is how much this affects you. So if you have post-radiation therapy inflammation, it could be an issue, or it could not be an issue. So it really depends. So what is the issue with the inflammation? That would be the question. Okay. After 38 radiation therapy treatments last year, I still have urinary issues. I have a burning sensation. I use the restroom a lot. I was prescribed Flomax, but is there something else I can do? Definitely. This is pretty common. Typically, it's something we try to manage so that it doesn't become chronic. Flomax, as such, is there to help prostate muscles to relax, to maximize the flow. So if the output is too low, this is where we can feel discomfort. If we have a good output, a good flow, then it's more natural and more comfortable. So this is what we try to achieve. But there can be a number of reasons to have these symptoms. So this needs to be assessed with either a radio-oncologist or urologist to know why these symptoms are there. And what about the flow splitting? Does that mean anything? Well, it means something is impeding the flow. We're not generating enough power. So is it the bladder that's not powerful enough? because we can rehabilitate the bladder. Do you show up to the restroom too early, so you feel like you have to go, but perhaps you don't actually need to? Or is there a blockage due to scarring? So, different causes require different strategies. Briefly, intestinal issues. Are they more significant with external radiation therapy or with brachytherapy? So brachytherapy are implants inserted in the prostate. So the rectum and the bladder don't really have any issues. However, radiation therapy treats the prostate, but the radiation does affect the surrounding organs. Okay. Intestinal issues, how long should they last after radiation therapy, or can they be permanent? So typically they last for a few weeks. Some patients don't have any intestinal problems. You know, a lot of them say, you scared me with that, but it didn't happen. So you just need to be aware. But in the majority of cases, after a few weeks, there is no longer an issue. There's a small percentage, typically less than 5%, that will have chronic issues. So this will be their new reality. Okay, short question. Is pelvic floor rehabilitation, like Kegel exercises, can that help with severe issues related to intestinal issues? Okay, so with intestinal issues, it's not quite as clear how helpful it is, but yes, it can help to a degree, yes. So, Dr. Vavassis, thank you so much for your time and for your advice. I'm sure that this is very helpful for the men listening to us tonight. Oh, actually, I thank you. Our next webinar will be on September 27th. We will discuss your role as a patient. This will be a panel discussion. I will be facilitator for this, and we will have patients who will discuss this with us. So please have a look at our website if you want more information. And on that note, I thank you for participating. Again, if you have questions, and I saw that there were additional questions that were asked, so these will be answered later on with our specialist at Procure, and they will give you an answer. So thank you so much. This was Mr. McQuaid. Please have a fantastic evening and see you next week.
Vous avez aimé les services de Procure? Alors n'hésitez pas à contribuer à procure.ca. Merci pour votre générosité.